Next, we're going to shift gears a bit, and we will have a talk by Dr. Brian Sullivan from the Princess Margaret Hospital in Toronto, Ontario, Canada, and he will speak on reirradiation following recurrence of head and neck cancer. Brian?
So again, I'd like to thank the organizing committee and the two co-chairs for asking me to deliver this lecture. How do I go forward here?
There's a trigger at the back as well.
At the back, wow. So I have no disclosures of any relevance, at least. So one of the things to be aware of is that the recurrent case today is probably not the same as the recurrence that we used to see quite a number of years ago. We have probably more resistant clones of radiation-resistant and chemotherapy-resistant tumors that have evolved to develop the recurrence. And as a consequence, our choices actually are narrowing down in that we don't have, we've already perhaps even used up most of our significant armamentarium. So the challenge in terms of what to do is more critical, especially in the systemic agent chemotherapy and even biotherapy, and certainly in the use of IMRT, which most of our patients now receive. So this is a difficult problem. On the other hand, we do have emergence of a more favorable group, which was mentioned by Robert, and we talked about it just a moment ago, and I think Jan will make a few comments about that as well in his talk, that the HPV population does have a more favorable outcome following progression of disease. And then we also have an abundance of radiotherapy techniques, which in fact has caused us more problems than help, because we end up now being confused as to what we should use, and in particular getting into issues about dose per fraction, shorter versus long courses, and whether or not we are able to deliver the treatments that we want to give in a successful way without causing significant morbidity. So we don't really understand, to some degree, the radiobiology of normal tissues combined with some of our agents, especially maybe even the newer targeted agents that may cause different effects on vascularity and so forth, and then also the outcome related, for example, following particle beam treatments such as protons and so forth. So this is a complicated area with a large and rather heterogeneous literature that's emerging that we're going to have to try and address, hopefully with clinical trials in the years ahead. Okay, so in the next 15 minutes, I will broadly address the headings that you see here, but they're not quite as crisp as you'd like, because there's overlap in and about these various areas, with stereotactic boost being used with some fractionated treatments, or with biotherapy, or with or without chemotherapy being used. So it's not a clean story, really, that you can look at. And I'm going to try and focus more on the randomized trials that we have available, rather than a single institutional series, although the latter do help to endorse some of the principles as we move forward. I won't be discussing nasopharyngeal carcinoma, palliative radiotherapy, or particle beam treatments. In optimizing the therapeutic ratio of reirradiotherapy, we need to think of a few important principles. Is the disease resectable? Hopefully it is. And if it is, and you can do salvage surgery, do we need to give radiotherapy at all postoperatively? And of course, in the unresectable situation, reirradiotherapy is generally linked to using systemic agents, hopefully with cisplatin, but often that is not possible at that time. Cisplatin being, of course, our most effective agent. And when we try to optimize the therapeutic ratio, we need to look at, as we heard earlier, the prior management in detail. Hisham has already addressed this to a great degree, but I will focus also on the interval since the prior treatment. It's very important for the fact that there is recovery of radiation injury that can take place as time evolves. And then, of course, there is the compelling issue about trying to decide which is the actual right fractionation, the dose, the technical issues, and types of equipment we will use for delivery of that treatment. I still haven't got this quite right. There. So we've already seen an outline of these prognostic factors, and I won't address this in any detail. And I will just remind us of the HPV positive story that we've just really got brand new data in press now from the RTOG, and I'm going to leave Professor Vermorken to comment on that. There does appear to be a substantial difference in outcome from the time of progression. There's also additional data that we haven't pressed that I took out of the slide deck also that addresses some of the earlier comments that we heard about if you find positive disease in the neck. So Pierre commented on that earlier. If you find that for HPV positive, they actually still do significantly better than the HPV negative population. When you do the neck dissection as a planned neck dissection and find disease in the neck, the HPV positive group will do better with that as well. So looking at some issues about sparing reirradiation, which is of course the crucial issue that we as radiation oncologists worry about because of the tremendous damage that we can do when we reirradiate. We do have the spatial or physical sparing using our fancy technical deliveries, but we also have to be very concerned about the biologic aspect. And smaller radiation fraction size I will comment on later, but also I mentioned earlier, longer time intervals permit degree of recovery. There's a classic paper from Nieder et al., which we always point out to the residents. They should read this for their exams because it does describe the fact that after 6 months post-radiation, spinal cord tolerance will recover by at least 25%, and brain tolerance will recover by even more within a year. So it's important to understand what you can do with your retreatment and what are the technical and other anatomic issues that are going to be the main constraint in delivering what would otherwise be a very dangerous treatment when we put these together, the two courses. And I'll also put this slide in just to remind us of an interesting observation which our colleagues from the University of Michigan have made, led by Avi Eisbruck, pointing out that the radiotherapy volumes using IMRT and regular fractionated radiotherapy, they do not ordinarily treat prophylactic lymph nodes or subclinical disease in the vicinity of the gross tumor volumes. And when you look at the data on which this is based now, 47 locoregional failures were detected among the 66 patients in this series, but 45 of those were in field. There were only 2 out of field. And it's almost as if the tumor was destined to demonstrate where it's going to come back in that interval before recurrence, and that will be a stable, relatively stable situation afterwards. So we do not normally treat electively. We try to keep the dose as confined to the target as we can. So let's talk a little bit about postoperative reirradiation. The classic data we have now, and I'm going to focus really on the main randomized trial that is available. I thank Hans Legendak, who's somewhere in the front here, who gave me a couple of slides to help me with this talk. And just to point out the French study from, at least Jano's study published in the Journal of Clinical Oncology, looking at a wait-and-see policy versus postoperative radiotherapy, randomized phase 3 trial for intermediate and high-risk disease. It was nicely balanced, as you can see on the right-hand side, for the more adverse features, although only 50% of patients had positive or close margins, extracapsular extension, or more than 1 lymph node. So again, this was a somewhat heterogeneous selection criteria, even within what we would ordinarily see as the highest risk. And the radiotherapy was what I think most of us as radiation oncologists would regard as a bit unusual. It regarded split course treatments of 9 days rest, along with concurrent chemotherapy with somewhat unusual dose, chemotherapy that has evolved really from the University of Chicago protocol with hydroxyurea given concomitantly and 5-FU. Fairly conventional radiotherapy fractionations, but remember these 9-day rests ending up taking almost 3 months to deliver this whole treatment program. So this is not an inconsequential issue for a patient who otherwise is suffering from recurrent disease. And one has to take that into account as well. And when you look at the acute toxicity for the radiotherapy arm, 28 grade 3 and grade 4 acute toxicity, and 8% or 5 treatment-related deaths, which are identified on the left-hand side of the slide. And if you look at late toxicity, watchful waiting versus radiotherapy, you can see that at 1 year following this treatment, 26% of the radiotherapy with chemotherapy arm have late toxicity of grade 3 or 4, and you can see listed the types of toxicity, which mounts up to 39% by the time you get to 2 years. So this is not trivial when you're embarking on this type of treatment. What is even more interesting, of course, is the locoregional control rate in this study, which showed significant difference in locoregional control, but no effect on overall survival. And what is interesting with the wait-and-see arm is the ability to salvage patients subsequently compared to the other arm, resulting in the 2 curves being basically overlapping in subsequent time periods. And the cause of death for the locoregional related deaths, the RT arm had less than the wait-and-see arm, but the treatment-related deaths were substantially more obvious not high numbers, but 5 patients of the cohort compared to none in the wait and see arm. So that's an important issue when discussing this with patients. So this study from our French colleagues has shown us that post-operative reirradiotherapy does provide the ability to achieve local control, but similar overall survival, significantly more grade 3 and grade 4 toxicity. And you can salvage in the wait and see arm, which is of interest, substantial salvage, in fact. And as discussed in that editorial in JCO in 2008, there's great room for improvement probably, but this has been an important study because it shows that we actually can accomplish something in this group of patients. So a lot of issues about fraction size, the technical details that I mentioned earlier, perhaps the avoidance of the split course regimes, because that really is a very major detriment to outcome in radiotherapy protocols if you allow repopulation to take place, and better selection, as has been mentioned by our previous speakers. So primary reirradiation is an important consideration that we're all aware of. Salvage surgery is often not possible for our patients. Reirradiation alone, there's very minimal data. It tends to be retrospective, single institution, a lot of heterogeneous radiotherapy strategies, and long-term survival is achievable, but it's only in a small subset. So we do struggle with this. And normally we would combine this with chemotherapy if we can, or more recently with cetuximab in the form of biotherapy or other new agents, hopefully in the future. So the classic data we have are the 2 RTOG trials, 9610 and 9911. Both trials use identical radiotherapy. Again, somewhat peculiar radiotherapy, if I might add. 1.5 gray twice a day for 5 days and then a week off, and keep repeating that, accumulating schedules of 15 gray 4 times. And in the 9610 trial, it used 5-FU and hydroxyurea, the Chicago approach again. And then in the 9911, much more intensified treatment with cisplatinum and paclitaxel and GCSF. And you can see the 2 curves that they've been combined together in a kind of a quasi-meta-analysis here, and you can see a significantly improved overall survival for the more intensified treatment. But on the right-hand side of the slide, you can see that it's not that it's not necessarily that nice a story, because there's substantial toxicity that happens in the more intensified treatment, with 17% getting grade 4 toxicity and with 4% having grade 5 toxicity and death from it, with the causes identified with pulmonary or infection or severe mucositis. So this is, again, a complicated decision point, especially when you look at the length of time it's going to take to give these treatments. And I guess one would wonder whether we could maybe optimize the radiotherapy schedule without the interruptions as well. I'm trying to advance here again. Sorry, let's go back now. And another way to possibly improve the intensity of treatment might be to add a stereotactic boost. And this, I just bring this in. This is data that's in press from the Mayo Clinic, and it's of interest because it does show that you can do very well in terms of local control with 82%, although this is a mixture, 2/3 recurrent disease, 1/3 of primary cases. But the recurrent boost, sorry, the boost that was given by stereotactic was 14 gray single fraction generally. And I just wonder whether we might be able to revisit that and perhaps fractionate that a little bit, because the long-term follow-up has shown late toxicity in 59 of these patients, 15 of them having temporal lobe necrosis, and the actuarial rate, as you can see, mounts up, so by 48 months it's up to 40%. And I think you could probably give that stereotactic boost a little bit more gently than 14 gray on top of a substantial dose of around 60 gray by regular fractionated treatment, and especially combining that with concurrent chemotherapy. And as we move on into stereotactic, just to touch on it a little bit, so stereotactic treatments traditionally evolved with the gamma knife, and they were more rigid framed type immobilization systems. Now we have very sophisticated robotic tracking and image guidance that we can use, and you don't need to frame them in the same way. There must be some way to get these to advance quickly.
Next, please, tell them.
Yeah. So as an example, the cyber knife has evolved, and it's a beautiful piece of equipment, wonderful, very high tech, very tempting to use, but it takes a fair bit of time to treat a patient with it, and there's some logistic issues. And it tends to therefore ignore the advantages of fractionation and use small courses of treatment, like about 2 to 5 fractions of radiotherapy compared to what you would have done traditionally. And so that area is evolving now with the move towards having more fractionated approaches to try and protect normal tissue, so you don't get into the problems that I mentioned a moment ago. An example here using CyberKnife comes from the Georgetown's paper back a couple of years ago. Again, a focus on the bottom of the right-hand slide, right-hand panel with the toxicity, with a death 2 weeks post-radiotherapy. That's not of certain what caused it, but then there's grade 4 toxicity. Again, arterial bleeding, soft tissue necrosis, fistula formation, and dysphagia requiring hospitalization. And we've all come to recognize that if you're going to get into the stereotactic area with the smaller dose per fractions, and you can see 30 gray, with the large dose per fractions with 30 gray as the median dose used in this study, in 2 to 5 fractions with CyberKnife, you're going to blow out some carotids. There's no way of getting away with that. It's a roulette wheel phenomenon. You will knock off some carotids by doing that. And that's the issue you have to basically be prepared to have and discuss with the patients when you're making this kind of decision. And everybody realizes that now when you're delivering these kind of doses, especially in the base of the skull area. And just to comment a little bit on why we fractionate radiotherapy, and I don't want to give you a radiobiology course here right now, but we always talk about the 4 R's of radiotherapy: repair, reoxygenation, redistribution, and repopulation. Some of these are in favor of addressing the tumor itself, but the most important one from the point of view of what we're talking about today, I think, is the repair phenomenon. Fractionation protects late responding tissues. If you use smaller dose per fractions, and we have ways of mathematically determining that using something called the alpha-beta ratio, and if you have small dose per fraction, you will spare normal tissue, whereas tumor and acute normal tissues are relatively fraction size independent. So this is an important issue. If you're going to start piling it in with big doses per fraction, you are going to have to expect toxicity, and it will be significant toxicity in a proportion of patients. So let's talk a little bit about bioreirradiation. This obviously is the nice substitute that you can use, hopefully, instead of using conventional chemotherapy when you've already used conventional chemotherapy. So there are some small studies, and they show good compliance and tolerance. Generally, the 2 that I'm citing here have had what again would be perhaps unusual radiation doses. It was continuous, but it didn't reach the threshold of what we would normally expect, like a 60 gray course to eradicate gross disease. So the authors of these 2 papers felt these showed feasible and encouraging responses, and I would note that the median overall survival was only 8 months and 9 months for the 2 studies. So again, we don't have an answer from that standpoint. Bioradiotherapy has also been combined with stereotactic treatment with all the caveats I mentioned earlier. Here's a study from Dr. Lartigot from France, again showing that if you use cetuximab, you can get a feasible delivery of treatment, but again, you get into issues with toxicity. 18 patients having grade 3 toxicity, 1 having toxic death from hemorrhage and nutritional problems, and again, the median follow-up on this was 11 months. The overall survival around 47% in that particular study. And as we move forward into other aspects, there's more tendency to use stereotactic treatments with bioradiotherapy approaches like cetuximab. Here's the University of Pittsburgh study just out. It's a retrospective study, again using the smaller dose per fractions, so 44 to 50 gray given in 5 fractions, and remarkably low toxicity profile. But again, look at the median follow-up, only 6 months. Now, as you look at 2-year outcomes, they are actually not too bad if you look at this. But again, I think we will wait further follow-up on this particular series. The final thing I'd like to just mention is intraoperative radiotherapy for recurrent head and neck cancer, partly because we're in New York, and there have been 3 series on this, 1 from Memorial, 1 from Beth Israel, led by Lou Harrison. And then UCSF have the most mature data with a 41-month median follow-up. And if you look at the local regional control rates down in the center of the panel there, they actually do pretty well. You know, look at that Beth Israel at 88%, and it's actually tolerated better than the stereotactic approach. So I think this is actually something that should be considered in prospective trials. There hasn't been a prospective trial yet in this area. The types of dose we're talking about are single fraction, intraoperative radiotherapy, 15 gray, and then also combining that generally with external beam treatment afterwards. If margins are positive, 12 gray. If margins are negative, 12 gray. If margins are positive, 15 gray is what is used at the BI. So just to conclude, and I'm taking this slide from Hans Legendak, who lent it to me, and I've adapted it a little bit. Optimizing radiation regimes. There are some practical and there are some scientific issues. Surgery is the preferred approach, but is often not sufficient. The questions that we're left with, and as Hans has said, the most ideal strategy has really not been tested so far. We don't know, we haven't seen a good assessment of small dose per fraction, continuous course treatment with adequate radiation dose, limited target volumes, and we also don't know what types of technical delivery we have. We've got so many different tools we can use now, and also exactly what the best combination is to combine with radiotherapy. So thank you for your attention.